what you're thinking. You think that you could be better off with somebody new. No, baby, no. You say you're leaving. Well, if you wanna leave, there ain't nobody stopping you. No, baby, no. I won't beg for your love, won't say please. I won't fall to the ground on my knees. You know I've given this everything, baby, honestly. Baby, honestly. I lie for you, baby. Die for you, baby. Cry for you, baby. But tell me what you've done for me. For you, baby. And only you, baby. The things I do, baby. But tell me what you've done for me.
I never cheated. Deleted everyone 'cause they made you uncomfortable. No, baby, no. These accusations, I can't apologize for something that I didn't do. No, baby, no. I won't beg for your love, won't say please.
Won't say please.
I won't fall to the ground on my knees. You know I've given this everything, baby, honestly.
Baby, honestly.
Baby, honestly.
I lie for you, baby. Die for you, baby. Cry for you, baby. But tell me what you've done for me. For you, baby. And only you, baby. The things I do, baby. But tell me what you've done for me. Tell me what you've done for me. Oh, tell me what you've done for me. Tell me what you've done for me. You know I've given this everything, baby, honestly. Tell me what you've done for me. I lie for you, baby. Die for you, baby. Cry for you, baby. But tell me what you've done for me. For you, baby. Only you, baby. The things I do, baby. Tell me what you've done for me. Tell me what you've done for me. Oh, tell me what you've done for me. Tell me what you've done for me.
Havana, ooh, nah, nah. Half of my heart is in Havana, ooh, nah, nah. He took me back to East Atlanta, nah, nah, nah. All of my heart is in Havana. There's something about his manners. Havana, ooh, nah. He didn't walk up with that, how you doing? When he came in, he said there's a lot of girls I can do it, but I can't with that. No one forever in a minute. That's on my night. And Papa says he got Milo in him. He got me feeling like ooh. I knew it when I met him. I loved him when I left him. Got me feeling like ooh. And then I had to tell him I had to go. Oh, nah, 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 nah. Havana, ooh, nah, nah. Half of my heart is in Havana, ooh, nah, nah. He took me back to East Atlanta, nah, nah, nah. All of my heart is in Havana. My heart is in Havana. Havana, nah, nah.
Jeffrey. Just graduated fresh on campus. Fresh out East Atlanta with no mountains. Damn, fresh out East Atlanta. Up on board like a traffic jam. I was quick to pay that girl like Uncle Sam. Here you go, ayy, take it on me. Shout the craving on me, get the eating on me, on me. She waited on me, shout the caking on me, got the bacon on me. This is history in the making, homie. Point blank, close range, that feed. If it goes a million, that's me. I was getting moolah, baby.
Havana, ooh, nah, nah. Half of my heart is in Havana, ooh, nah, nah. He took me back.
Hello, good afternoon. Welcome back to this session on nursing staffing. I'm Wai Mei from Singapore National Neuroscience Institute, and I'll be the moderator for this session. Hope you have enjoyed your conference so far, and I think I'm between you and going home. So let's have our first speaker for today is Dr. Brendan Martin from United States, and his topic will be on diversity, education, and nursing shortages, results from the 2017 U.S. Nursing Workforce Survey. Let's welcome him.
Good afternoon. My name is Brendan Martin, and I'm a senior research scientist from the National Council of State Boards of Nursing. And my colleague and actually the principal investigator for this study, Richard Smiley, wasn't able to attend the conference this year. So I'm here today to discuss the results of the 2017 Nursing Workforce Survey. So for today's presentation, I just want to touch on 4 broad themes. I want to give you a little bit of a background for the study, what the purpose for the research was. And then we're going to touch very briefly on the methodology, so how we went about collecting the data that we used in the analysis, and then the methods that we used for actually analyzing the data themselves. Then we're going to touch on very specific results for the 2017 Nursing Workforce Survey, and then we'll finish up with the conclusions that we were able to draw from our analysis. So as many of you may know, racial and ethnic diversity has been steadily increasing in the United States over the last few decades, and it's projected to continue to do so in the future. However, one of the things that we've seen, we conduct a nursing workforce survey biannually, so essentially 2013, 2015, 2017. And we've noticed that essentially there's a lag in racial and ethnic diversity within the nursing workforce. So one of the things that we wanted to investigate in our analysis was whether or not licensing standards and increasing educational requirements were in effect functioning as barriers to Hispanic, Latino, African American, and Asian nurses entering the workforce. So what we did is we conducted the 2017 National Nursing Workforce Survey. And for those of you who are not familiar, it's a stratified random sample of RNs and LPNs practicing across the United States. So what's nice about this study is it's a very robust data set that allows us to draw population level estimates, and the estimates that we are able to use, then we can project and essentially understand the proportion of nurses within the workforce that meet certain criteria. In this particular instance, for the 2017 survey, we had approximately 49,000 RNs who responded and just over 40,000 LPNs who responded to the survey. So to get to the results, without further ado, the RN nursing workforce, one of the things that we saw which was very heartening is that actually there's been an uptick in racial and ethnic diversity within the nursing workforce, in particular among newly licensed nurses. So you can kind of see that the trend here is, with the x-axis being number of years licensed, that as you get into the older cohorts of the nursing workforce, you see a little less diversity. You see about 90% self-reporting as white Caucasian. But when you look at that newly licensed cohort, which is that 0 to 1, kind of in that first column right at the beginning of the x-axis, you actually see that of the respondents to the 2017 Nursing Workforce Survey, 30% self-identified as a racial or ethnic minority. So we wanted to dig into that a little bit, and we wanted to understand what are the cohorts that are effectively driving that uptick in racial and ethnic diversity. And what we found was that it was by and large mostly Hispanic nurses, but also African American nurses. So Hispanic nurses accounted for about 13% of newly licensed RNs in 2017. And African American nurses accounted for about 10%. You can see that the Asian subset, it wasn't necessarily in that newly licensed cohort where we saw the greatest spike. That was in the 11 to 15 range. But you can kind of see in that newly licensed to early career kind of cohort, that 0 to 15, that really hovered around 10% for Asian respondents as well. So one of the things that we saw is it was actually kind of across all 3 of the subgroups that we were interested in. The LPN nursing workforce, it was an even more pronounced trend. So what we saw was that about 36% of newly licensed nurses self-identified as non-white. And that was actually very, very close to what we see in terms of the demographic profile of the United States, which is about 39% right now. Otherwise, you can see, though, that this follows a very, very similar trend. So for newly licensed and early career nurses, that's really where you see the diversity uptick within the LPN workforce, similar to the RN workforce. So as we did before, we also wanted to understand what was driving that trend within the LPN workforce. And what we found was it was very similar, obviously, to RN, but it was a little bit flipped in that African American respondents accounted for the largest proportion of newly licensed LPNs at just about 22%. And then Hispanic respondents accounted for about 17% of newly licensed LPNs. In this particular instance, Asian respondents also had the largest proportion reported in that newly licensed cohort. Turning a little bit to education, one of the things that we really thought was very, very heartening was that both among Caucasian, white Caucasian respondents and ethnic and racial minority respondents, we saw that the BSN or higher entry-level credential was actually above 50% for both cohorts. It was very, very comparable. And in fact, when you look, let's see if I can get the mouse to work. When you look at the actual proportion of baccalaureate African American respondents and Asian respondent, it actually exceeded that of their white counterparts. While Hispanic, the highest proportion was associate degrees, you can see, however, that master's entry degrees, Hispanic respondents actually accounted for the most there too. So rather than essentially having education, heightened education and licensing standards act as a barrier to entry into the profession, one of the things that we found was that the workforce, the nursing workforce itself, was actually slowly becoming much more in line with the demographic profile of the United States and becoming ever more diverse. And this preliminary evidence, we would caution that essentially we don't think that we've determined absolutely definitively without a shadow of the doubt that eventually some of these standards might not act as barriers. But we really do believe that the preliminary evidence that we've been able to tease out of the data for the 2017 survey suggests that increasing education standards really isn't acting as a barrier for Hispanic, Latino, African American, and Asian nurses. Now, one of the things that we, of course, want to do moving forward is we want to continue to track this trend through our future survey administrations, the next one being 2019 this year, later this year. And we'll hope to be able to confirm that trend and report back similarly good findings in future presentations. But for those of you who are interested in the results beyond just what I've presented today, I should mention that the 2017 Nursing Workforce Survey, the full report can be accessed both on the National Council of State Boards of Nursing website, and it was recently published earlier this year in the Journal of Nursing Regulation, and is accessible there. So if you have any questions for me, I'm happy to take them, but if you also just want to read the full report, please feel free to access that as well.
Hi, any questions for Dr. Brendan Martin? Would you like to go to the mic?
Hello. You had a column of the associate. You had a bachelor's, then you had the certificate, and then the associate. What
Yes. This one?
What was it? What is associate?
Oh, what is the associate degree? Oh, that's an excellent question. Yeah, so the associate degree is a two-year kind of practical degree. So it's one in which they would have gotten basically more workforce-related training. So it's a little bit shorter than a baccalaureate and generally considered a little bit less, well, I shouldn't say less rigorous. It's just a shorter program of study.
Is it the one that come after the learner program? The
learn-
learners. You had the learners, then you had the RN.
I'm not sure I understand the question. Sorry.
You had the student or the pupil or the learner, and then you had the registered nurse. Is the program, let me rephrase.
I'm sorry, yes.
Yeah, you get students
Yes.
or learners. They qualified into RNs.
Oh, okay.
So is the associate in between?
It's a student degree.
Okay.
So essentially it would be like a two-year college degree.
Okay.
Yes, sorry.
All right.
Thank you very much.
Any more questions? Otherwise, let's thank Dr. Brendan Martin. Moving on to the next speaker is a PhD student, Shen Biyu, and her topic will be the application of EAP theory in the cultivation of nurses' innovative ability. Let's welcome her.
Good afternoon. Dear Chairman, ladies and gentlemen, my name is Biyu Shen, come from China, the second affiliated hospital of Nantong University. Now I'm also a PhD student in Suzhou University. Today, it's my honor to speak here and share with you our research. The application of EAP theory in the cultivation of nurses' innovative ability. Employee Assistance Programs, EAP. EAP originated in the United States. It's the center of systematic and long-term mental welfare and support projects for employee. EAP pays attention to culture, innovative mode, and give prominence to assistance. Objective. Innovative behavior is essential of nurses in today's world. We want to train excellent nurses based on theory and explore its effect on nurses' innovative ability training. Our hospital launched the Excellent Nursing Talents Training Implementation Plan based on the EAP theory. The project was implemented in July 2015, and the training period was 3 years. According to the relevant standards, selector excellent nursing talents, EMT, and set up the special team, selector tutors, according to their own selectoristics and training programs. Establish a training program suitable for professional development and lead team members under the guidance of the tutor. Carry out training, comprehensive evaluation of team members' innovative ability after the end of the training period. Here are some details. Competitive speech, both ability and political integrity. Finally, there were 27 nurses who had taken part in the training. Each of them has 30,000 RMB as a funding, designed the logo. And we are a team. It means united, sunny, and hopeful. And information exchange through WeChat group. And a daily English oral practice group. Holding reading meetings to realize knowledge sharing. Inviting statistics teachers to give a series of lectures. And the tutors are specialists in nursing, medicine, and management. Every tutor gives us lectures, including scientific research methods and skills of writing papers, and so on. For the entire training process of EMT, we must evaluate feedback, reward, and unlimited. And this is stage assessment. The final report. After they finish the plan, we use the evaluation tutors. The one nurses innovative behavior skills. This skill was developed by the nursing school, by the Baolin, a nursing school at Shanghai Jiao Tong University. The second, the nurse organization innovation atmosphere scale. Results, the scores of EMT's innovation behavior, generating support, implementing ideas are higher than other nurses. Second, the innovation ability of department nurses with EMT is higher than that of the nurse without the EAT department. Third, EMT's organizational innovation atmosphere tutor score as organizational innovating incentive. Resource applies is higher than other nurses. Fourth, the organizational innovation as atmosphere of the department nurses with EMT is higher than that of the nurses without the EMT's department. We have get also achievement. For example, papers, patents, and funding. Last year, Chinese scientific technology value nursing in our hospital ranks 15th in the country, the number one in the Southern Province. Conclusion. The training of excellent nursing talents are based on EAP theory can improve the innovation ability of the training target and at the same time improve the innovation ability of the nurses in the department where the training objective is located. So, find a group of people who challenge and inspire you. Spend a lot of time with them, and it will change your life. This is my hospital. Welcome to China. Thank you very much.
Thank you, Ms. Shen. Any question for Ms. Shen?
Sure. Okay, thank you so much for your sharing with regard to what is happening in Chinese hospitals. And I think in one of your slides you mentioned that the tutors are specialists in medicine, nursing, etc. So I was just wondering, would you please share more about what is the criteria, the eligibility for becoming a tutor in your program? Thanks.
Thank you. This is a very good question. Because the EMT training is similar to the graduate, is postgraduate management. So the tutor is also the postgraduate tutor. So this is, when the tutor and the EMT, the nurse come from the same area, I think it's can sharing the achievement, and achieve the double win situation. Thank you.
Thank you.
Any more questions? Otherwise, let's thank Ms. Shen. Our next speaker, Dr. Carol Tuttas from United States, and her topic will be advantages of global migration, culture, diversity, and beyond. Let's welcome her.
Thank you. Good afternoon. For the next 10 minutes, I would like to draw your attention to the advantages of global migration of nurses in the context of the landscape of nurse migration, advantages of global nurse migration, and the roles of foreign educated nurses in the home and destination countries. It would be good for you to know that I work for the Commission on Graduates of Foreign Nursing Schools in Philadelphia, Pennsylvania, in the United States. I'm the Chief Learning Officer for the organization. When we talk about nursing workforce migration, we're referring to the movement of a highly skilled cohort of workers, particularly from, and usually from, developing countries into developed countries. This is an effect of globalization, which when we say that, we're talking about an increase in interactions and integration among people, companies, and governments worldwide, which has cleared a path of opportunity to support the means and ways for nurses to mobilize as they seek to improve their lifeways, professional development, and careers. The United Nations defines a migrant as anyone who changes his or her country residence. I think I skipped one there. Let's turn our attention to some of the migration-related empirical facts. Did you know that there are over 260 million migrant persons worldwide today? 1 in every 30 people is a migrant. Half of them are women, and 50 million of them are children. Since the year 2000, the rate of international migration has increased by almost 50%. That's a tremendous statistic in light of the fact that that's a speck of time we humans have walked on this planet, and another component for us to consider when we think of keeping up the pace with managing the advances in technology and globalization. 7 out of 10 migrating persons are within the age range to contribute to the workforce that they are headed to. And migrant persons contribute to economic growth both in the country of origin and in their destination countries. If you're interested in keeping up with UN statistics like this, you might want to mark down the hashtag #4migration. That was our source for that data, FOR migration. There's about 21 million nurses and midwives worldwide. There's probably more than that now. This, I believe, is 2017 World Health Organization data. 50% of the health workforce globally consists of nurses and midwives, which translates to 50% of migrating healthcare professionals are generally in that category. The current shortage of 9 million nurses and midwives globally is expected to have some relief over the next decade, but certain areas like Africa countries and Eastern Mediterranean regions are not expected to see such improvements. Typically, the nursing shortages are mostly a maldistribution effect. If you took the 21 million nurses and distributed them differently, there would be a far less negative impact of shortages. We're all aware of the push-pull factors that are well documented in the literature in terms of motivators for nurses to migrate: money, careers, safety and security. And at a lesser macro level, and other factors that would influence where a nurse might decide to migrate to in terms of a destination country would be shared language and culture. That would be an attractor. Curriculum being comparable is a big factor. Language, of course, is a very important factor. Geographical proximity, ease of travel, and existence of a similar community in the area are also pull factors for the nurses. There's a lot of advantages to having nurses migrate in our globalized environment, where, as Brendan pointed out, we're seeing increasingly more diverse populations everywhere, in every country. Therefore, you need to, as we all know, aim to get a healthcare workforce that can be matched well with that new population. The economic and social factors are huge for migrating nurses. In addition to supporting their families and the gross domestic product in the home country by remissions, migrant persons also benefit the destination country economically. Migration is actually recognized by the United Nations as an engine of economic growth and entrepreneurship. In 2017 alone, migrants sent $600 billion in remittances to developing countries. This is 3 times the amount officially sent in developmental aid globally. Migrant persons typically send 15% of their income to their home country, and the other 85% is being spent in the destination country, which will help in terms of taxes and withholdings and that support government programs and the population. So they're contributing to 2 countries, not 1. The United Nations Global Compact for Safe, Orderly, and Regular Migration was adopted in 2018 and offers 10 principles under 4 domains of human rights, labor, environment, and anti-corruption to support effective management of migration. Sadly, since 2000, over 60,000 migrants lost their lives in dangerous journeys. The Global Compact is the first initiative ever to cover all aspects of migration holistically and comprehensively. Nurses are educated about caring for culturally diverse populations. However, we need to hold ourselves each individually accountable to maintain currency in terms of best practices to deliver transculturally sensitive care. Transcultural competence includes maintaining awareness and staying informed about migration patterns, trends, empirical facts, and the correlation of these entities to our roles in the care of diverse populations. Migrant patients and families have experienced their own unique journeys, impacting their psychosocial conditions and responses to the healthcare interventions we deliver. At a macro level, the nursing profession is well positioned, and I suggest obligated, to advocate and contribute toward the development of solutions for migration-related issues such as human trafficking and human rights. These are our mandates and our responsibilities as this profession. Thank you very much.
Thank you, Dr. Tuttas. Any question for Dr. Tuttas? No? Hey, there's one.
Oh, there is. Oh, I'm sorry. I can't see the person, but there we are.
Thank you so much. There's just one question. Did you mention about the advantages? Did you outline the advantages and the disadvantages of migrants? Was they mentioned?
Yes, I looked at nursing in particular, although I do give some statistics about migration in general. But in terms of the benefits to both the destination and home countries, that often isn't regarded when we talk about, there's a lot of discussion about ethics when we talk about nurse migration. And we hear a lot about that at CGFNS as well through our applicants. The remittance that's provided to a home country provides a highly relied upon contribution to gross domestic product support, not just to families, but to whole countries. And of course, these nurses that migrate to a destination country are contributing to that country as well in terms of the needed professional support, care delivery, and they're spending the other 85% in their destination country. So that's one very important advantage.
Yeah. Thank you so much. You also made so a scary announcement of the migrant workers in the not the reduction that we're going to face in the future, that we're going to have migrant workers. And then you mentioned something about Africa in the Mediterranean. And you are from the United States, eh? Are you from the United States?
Yes.
Yeah, and then it's a country up in Africa, and then the Africa in global. And we actually are the people that seek jobs where the money pays out more. So we are the people that's going to America, Vancouver, North America, Abu Dhabi. The south of Africa goes to Abu Dhabi and the Emirates, where the people are paying more.
Yes.
But the migrant workers, from my view, is like, it's going to be like everybody's going to seek where you're going to benefit for your lifestyle. That is how I see it. That is just a comment. It's just a comment.
Yes.
So wherever we are, we're going wherever in the world where we can benefit. That is just my comment. Thank you so much.
Thank you for that. Thank you.
Thank you. Thank you, Dr. Tuttas. Okay, before I call for the next speaker, I'm doing an announcement. I have two missing presenters. And can I have Xing, Xueyan, or Nico Sciasci up here in the front? Okay. So Xing Xueyan, okay, she's here. Okay, my next presenter, Ms. Xing Xueyan. Her topic will be mobile nursing quality management in China. Let's welcome her.
I'm very pleased to take an oral presentation here. I'm from Beijing Pinghua Changgeng Hospital. I am a nurse anesthetist. Now I will share with you about mobile management. My topic is mobile nursing quality management in China. Nurse daily work tells us time is life. They must to take part in the rapid first aid. They need to provide services for the surgery in the operation room. They should to take a continuous renal replacement treatment in the intensive care unit. And they should to make preparations for the anesthesia, open the IV, calculate the input and output, and finish the record. Besides, they must finish the treatment and check the record and something else for administration. That's all? No, nurses were asked to do more. In China, for promotion, nurses need to do more, include learn knowledge and practice nursing skills, then pass the knowledge test and operational examination. In China, for every nurse, time is limited and precious. At the same time, there are some challenges for the head nurse in China. The first one is further education. Based on the limited time, when, where, and how to organize the further education to update knowledge. The second one is daily information transmission. when and which is the effective way. The third one is the human resource. Scheduling tools and emergency arrangement are important. The last one is meeting and training. How to let as many staff as possible to participate without increasing time consumption, and how to improve the effect. Chinese head nurse did some attempts in China. The traditional methods include morning meeting, ward round, regular meeting, telephone follow-up, and health guidance after discharge. In past years, some researchers used the email to keep communication with patients, pay attention to the development of disease, and provide health guidance for patients in telemedicine nursing. Some researchers used the telephone, QQ, email, and other information technical means to timely guide and help discharge the patients. In recent years, with the popularization of the WeChat, some researchers researched the WeChat can timely and effectively release information of the department, which is simple and fast, improve the satisfaction of nurses, enhance the level of nursing management, and is worthy to be popularized and applied in clinical nursing management. Now, let me share with you about the functions of the WeChat. The first one is chat. It is supports for sending voice messages, videos, pictures, and text. It is a chat software that supports multi-population. The second one is add friends. WeChat supports 7 ways to add friends: finding micro signals, checking QQ friends, checking mobile phone address book, and sharing micro signals, shaking, and so on. The third one is the real-time interphone function. Users can talk to a group of people through a voice chat room, but unlike voice in a group, the message in this chat room is almost real-time, without leaving any records, and can still chat in real time, even when the mobile screen is closed. The fourth one is the WeChat mini program. It is an application that can be used without downloading and installing. It relies the dream of the application at your fingertips. Users can open the application by swiping or searching. And the last one is the WeChat public platform. It is a self-media activity that allows one-to-many media-like activities. There are some studies on the application of WeChat in China. It includes nursing management, informatization nursing management, quality management of nursing medical records, and nursing education. That all outcomes tell us the WeChat is useful. Now let me share with you about one mini program for nursing schedule. In China, the number of mini programs exceeds 1 million. There are some mini programs that support subway and bus service. At first, the head nurse creates a department, and then it has some functions include scheduling, examination, and approval of leave, status, and settings. After finish and publish the schedule, it notifies all staff for the first time, and then only those who change their schedule. And we could look ourselves schedules anywhere with my telephone. Next, I will share you with the WeChat public platform. It is an element of the WeChat. It has some functions. The first one is group sending. It actively pushes important notices or interesting contents to users. The second one is automatic response. Users take the initiative to get regular messages from the public number according to the specified keywords. The third one is one-on-one communication. It provides a one-on-one dialogue answering service for users with special questions. The last one is two-dimensional called subscription. If you're interested in the WeChat public platform, you could choose the last one. This is the WeChat public platform of my department. And this one is the WeChat public platform of nursing and anesthesia forum in China. And this is the WeChat public platform of Beijing Nursing Association. The last one is the WeChat public platform of Chinese Nursing Association. Overall, WeChat in nursing management include some aspects, include the human resource, the further education, nursing quality monitoring and intervention, and the questionnaire. The WeChat can help us in the nursing management. Based on the WeChat, nursing management can efficiently is efficiently and is not restricted by the time and the space. The WeChat is popular in China. I think in the future it can help us much more in the management. And last, thanks for your listening and welcome to China.
Thank you, Ms. Sin. Any question for Ms. Sin? No? Let's thank her. We'll move on to our next presentation. We have Assistant Prof. Jenniffer Paguio. Her topic will be Diagnosing the Nurse Work Environment of the Philippines, a territory-wide study. Let's welcome her.
I'm Jenniffer Paguio. I am a PhD candidate from the Chinese University of Hong Kong, and I'm also an assistant professor at the University of the Philippines, Manila. The importance of positive practice environment and nurse work environment has been extensively discussed throughout the conference. Just this morning, President Annette Kennedy mentioned about the complex issues in source countries, such as the Philippines, that will experience, if not already experiencing, a nursing crisis. So I will not go into the details of the background of work environment. In line with that, this study is done as part of a 3-phase PhD dissertation to inform policies and practice to improve work environment in the Philippines. So the aim is to study systematically the state of work environment in my home country among and referral government hospitals in the Philippines. So I used the Dunabedian model of quality care to establish a framework to guide this study. The first objective is to describe the structures in the work environment, then the processes, the interaction between these two sets of variables, and their interactions with the outcomes that I have set for the study. So this is a mixed method, sequential exploratory study, a quantitative to qualitative design. I used cluster sampling to obtain to get consent from nurses from 5 regions in 7 tertiary and referral public hospitals among 991 frontline nurses. So the data collection is at the level of the nurse with a self-administered survey, hospital statistics record at the level of the hospital, and 8 focus group discussions among different levels of nurses. So as this is a mixed method study, there are several points of integration which actually informed the focus group discussion questions. These are the instruments that I used to compose the 79-item self-administered survey among the frontline nurses. And the key areas for exploration for the focus group interview focused on roles and return, relationships, workload, and quality of care. Now, for the results, as you can see here, the occupancy rate across the 3 clusters of hospitals is very high. For a hospital to function well, it should be at around 80% occupancy rate, but across the board in all the hospitals, it's 146% occupancy rate, with the minimum at 99% to a maximum of 223% across the 7 hospitals. So we have a 75.5% response rate among the frontline nurses. Just to describe the workforce, around 1 out of 4 of the frontline nurses earn around $290 a month. This reflects the 18% non-permanent frontline nurses. But I highlighted there that it can go as high as 80% of non-permanent frontline nurses in a hospital. 19% have a post-baccalaureate degree, and the respondents had an average of 4 to 5 years of experience in the hospital. But they only have engaged in 3 seminars and trainings for continuous professional development per year. For workload, the usual work hours in the Philippines is 8 hours, although some hospitals practice the 12-hour shift. But using the 8-hour mark, on the average, Filipino nurses that participated in the study worked for 10 hours per shift, of course, with overtime. And 40% of their time is spent actually on indirect care. This is because they are taking care of, one nurse is taking care of an average of 22 patients in general wards, which can go even higher, as sometimes one nurse takes care of 1 whole unit. In the acute care, it's 1:8 nurses. And the acuity was greatly varied across the hospitals, but one of the areas that imposed a lot of nursing care need is the fact that patients had inadequate resources. So overall, looking at the work environment, it's still favorable according to the frontline nurses. The same manner, their relationship with physicians is still favorable, as well as nurse autonomy. There's adequate nurse autonomy. However, the greatest area for improvement is in the area of leadership and management support. Specifically, as you can see here, across the board in all the sized hospitals, the staffing and resource adequacy is the lowest. So although there is a variability across the different sizes of hospitals, it's very obvious that the large hospitals had the most favorable environment, while those medium-sized hospitals, sizing between 300 to 600 bed capacity, had the lowest work environment. In terms of job satisfaction, the highest still is among the large hospitals, and they had the lowest burnout risk. While the medium-sized hospitals obviously had the highest burnout risk and highest intention to leave, to as much as 39% who intend to leave within the next 6 to 12 months. The lowest job satisfaction is in the smaller hospitals, but the perceived quality of care improved between the previous shift and the last year. So to look at the relationship between the structures and process variables vis-a-vis the outcomes, the factors that were seen as associated with higher job satisfaction is that when a nurse, the frontline nurses who had higher autonomy and higher leadership management support had higher job satisfaction, obviously. But for burnout, being a contractual nurse or a non-permanent nurse was associated with higher burnout risk, as well as those who spent more time on overtime. However, those with higher leadership management support and better relationship with doctors had lower burnout risk. For perceived quality of care of the nurse, across the board, lower acuity of patients, higher nurse autonomy, better relations with physicians, and longer available time for each patient care was associated with better perceived quality of care of the nurses at the unit level. But at the hospital level, being a contractual nurse was associated with lower quality of care, while higher autonomy and lower patient acuity was associated with higher quality of care. For intention to leave, as you can see here, nurses who are contractual or non-permanent, shorter years of service, lower autonomy, and lower leadership and management support were associated with higher intention to leave, while those with longer overtime was associated with higher intention to leave. For the hospital level, if you are a non-permanent nurse, shorter years of service, and lower autonomy, you are most likely more associated to leave the hospital. And the same predictors were generated for intention to leave the country. So we wanted to examine how these unfavorable structures would impact the outcomes and whether processes can actually enhance them. So will enhancing autonomy, leadership and management support, and physician relations improve outcomes? Across all the regression analysis that we ran, we found two significant findings. When we looked at high patient acuity that is associated with poor perception of quality of care, when we increased nurse autonomy and increased nurse-doctor relations, it actually was associated now to better perception of quality of care, which means that there is potential use to improving processes to have better perception of quality care. However, surprisingly, when it comes to intention to stay, longer years of service, when you increase nurse autonomy among those with longer years of service, the longer they go, the intention to leave goes higher. I would prefer to share to you, I would really like to share with you a lot of the findings of the qualitative, but I would like to focus on intention to leave. This is just a conceptual model that evolved from our focus group discussions on the issue of high intention to leave. We found that the high intention to leave, the nurses expressed that the high intention to leave, they related it to low job satisfaction, which they related eventually to low job security, the inability to provide their families unjust compensation for workload, especially for contractual nurses, and the distrust in the promotion process because it takes a long time for them to get promoted to permanent positions. As also, low job satisfaction was associated, or they described it as part of high workload and strained relationships with leadership. And job stress, they related it also to high workload because of high overtime and limited actual time for patient care, and strained relationships. In this figure, I just wanted to show you a summary of the structure variables above, but also below here, you can see that in the nurse autonomy, nurses also described a sense of false autonomy, wherein they're forced to make independent decisions in the unit because they're left alone, sometimes taking care of a whole unit on their own, even as a contractual nurse. And of course, their experience of a lot of task shifting across professions, which the nurse is left with the burden to doing all these things. And of course, they highlighted their strained relationships and the distrust with the hierarchy. However, they did highlight that relationship with physicians and across their healthcare team members and fellow nurses, communication and teamwork actually helped them deal with the high workload. So in conclusion, the nurse work environment of the Philippine public hospitals is at high risk. Although there is potential value in addressing workload issues by enhancing autonomy, leadership and management support, and fostering physician relationship, I would like to urge and emphasize that there is evidence to support the greater urgency and rationale to address the employment status, workload, nursing workforce, and nurse work environment to achieve better nurse outcomes. So this study echoes that there is no single solution to nursing issues, rather an array of specific actions that promote or aimed at promoting good work environment. So for my next phase, actually now I have shared the results of this study to all the participating hospitals, hopefully influencing their policies to improve work environment in their own units. But I'm also doing a quasi-experimental study to test whether teamwork and quality improvement can improve work environment towards nurse outcomes. So thank you very much.
Thank you, Jenniffer. Any questions for Jenniffer? Oh, this one.
Thank you, that was very interesting. I'm just wondering, when you shared back the information with hospitals, what recommended standards did you advise them? So like patient ratio or direct care delivery time?
Yes. When I shared it to the hospitals, where there were varied reactions across the board, the medical center chiefs and the chief nursing officers were there. I recommended that they comply with the national standards of, well, it's still high, 1:12 ratio, because at this point, even though the national standards for staffing is 1:12, it is not complied with. Also, I recommended that they really lobby for increasing their authorized bed capacity. Because although their authorized bed capacity is set, they really have to take in more patients that they can. There is a mandate that no government hospital is allowed to refuse patients. So that may be an issue. So I recommended that they study workforce and workforce planning, as well as improving their authorized bed capacity. Thank you.
Thank you for your presentation. It was very interesting.
Thank you.
Did any of your findings highlight any generational trends in the feedback?
I'm so sorry, any generational?
Generational trends. I'm not sure what the average age is of your workforce.
Oh, yes. The average age of the workforce, I'm sorry for not showing it there, it's around 29 years old. There is a generational difference, though. They highlighted it as well in the focus group discussions, wherein they attributed the possibility of the strained relationships with the leaders and managers because of the difference in generation. So another recommendation that I shared with them is that to enhance the relationship with the upper nursing management with the front line, that may enhance their teamwork as well and their collaboration. Thank you.
Sorry, I'm not too sure whether I should thank the Philippine governments, because we do have a lot of Philippine nurses working with us in Singapore, and they are lovely nurses to have as our team members. But saying that, I'm sure you are facing a lot of shortage over your side. I'm just curious, when you mention about increasing their autonomy, and yet you mentioned about having just one nurse to so many patients. So how do you actually go about it? And another thing is that you really face a lot of shortage of nurses back home. So other than recruiting your own nurses, do you all think about having nurses from other countries coming in? I mean, I'm just curious to know.
I'm in no position to say whether we are open to recruiting nurses from other countries, as I am not in regulation. But although we recognize that, we can't say no to nurses leaving the country. At the end of the day, feeding your family, providing your family is priority. What we can do is we can try to improve the work environment, regulations, workforce, to take care of the nurses so that they opt to stay. As Annette was saying earlier, nobody wants to leave. But if they have to, they do, because there's greener pasture. That's why the nurses probably said about false autonomy, is that they increase the autonomy because you're left there, you gain competencies to manage a huge number of patients. And as you go along the years of service, you get probably fed up. And that's what they were saying, that you get fed up waiting to be promoted, to have better salary. And you get to a tipping point that you just want to leave. And when they build that autonomy and then they discover that, hey, there's a better place for me where I will be better appreciated, then they tend to leave. So I think that's a huge challenge for us, and my bosses from the Philippines, my colleagues are here as well, and I hope to share this data with them so that we can plan better together. So thank you very much.
Thank you, Jenniffer. Okay, we will move on to the next speaker. This is adjunct Prof. Alanna Geary from Australia, and her topic is what is achievable for enhancing the image of nursing midwifery through leadership in action. Let's welcome her.
Thank you very much. As was just said, my name is Alanna Geary, and I'm the Executive Director of Nursing and Midwifery in Metro North Hospital and Health Service. Just to give you a bit of context, Metro North Hospital and Health Service is actually the largest health service in Australia and comprises greater than 8,000 nursing staff. And actually, I think At our last census, it was probably about 9,200. In total, there are 20,000 healthcare professionals working in Metro North, and Metro North comprises 2 tertiary referral centres, 2 large regional centres, 1 rural community centre, 3 directorates, which are mental health, community and oral health. So it's a very large geographical area. If I want to go from one end to the other, it's about 50 kilometres. So it takes me my day to actually get to the other facilities in my service. My role as the Executive Director of Nursing is to actually have professional oversight of all the nursing staff in the HHS. So about 5 years ago, Queensland in particular had been completely disenfranchised by government, and we'd actually lost quite significant numbers of nurses and midwives. I came into the role about 4.5 years ago, and what I was faced with was actually a group of nurses, all 9,000 of them, who were actually feeling particularly vulnerable. We had lost significant numbers of nursing due to redundancy and trying to downgrade services, and we really wanted to make sure that they felt that they were part of the leadership journey. 2 years ago, I actually came to ICN, and there was a quote that was actually around at that time, and it was, "If you're not at the table, you're probably on the menu." And that really struck a chord with me, because what it made me realise is that nurses and midwives in Metro North were probably not really at the table, and therefore we were on the menu. And I needed my nurses and midwives, all 9,000 of them, from grades 1 up to 13-2, which is the position that I'm currently paid in, to be part of that leadership journey. Leadership is not just my responsibility as the Executive Director of Nursing and Midwifery. It belongs to every single nurse. So we needed to foster capacity, capability and contribution. I needed to focus on dynamic teams and really taking leadership and the leadership journey back to the grassroots of our clinical areas. I wanted to enhance a culture of lifelong learning and make sure that every single nurse knew that it was their right and their responsibility to be part of that journey. And we really wanted to emphasise excellence in practice. Metro North has chosen not to go down the magnet accreditation route, but having said that, we actually fully believe in the principles of magnet, and therefore we were really keen to pursue that journey. So what were we going to do? Well, together with my education group, and a couple of them are actually in the audience today, and my other directors of nursing from across the HHS, we sat down and worked out what would be the best strategies to actually empower our nurses and midwives. I went and spoke to the Chief Executive, who was fortunately very much on my side, and I've subsequently had 2 Chief Executives since then, and equally, they were just as supportive of what we were trying to do. So I started with my middle managers, because I really felt that if I could get the message to them to commence the journey, then it was going to be easier to feed down. I made it compulsory for every nurse grade 7, which is your nurse unit managers, your clinical nurse specialists, nurse practitioners, nursing directors, directors of nursing, to actually attend. Now, while I mandated that they attend, of course you always get a few stragglers, and I can't force the issue, but we did manage to get 86% of our mid-range nursing and nurses and midwives to the sessions. I actually used some of my university colleagues to come and speak to these groups, and really what I wanted to do was get across that everybody is on a leadership journey and everyone has a leadership trajectory, and we can all contribute to strong leadership in our facilities. After I'd done the nurse middle managers, and interestingly, if any of you have been to any of the magnet accreditation surveys, you will have seen a woman by the name of Amanda Gore who dances and prances around a stage with gratitude glasses on and fairy wands. But it was a really enlightening 4 hours, and she talked very strongly about being part of the message rather than part of the problem. I then went down to clinical nurse specialists, as in my nurse grade 6s, who are our clinical nurses at the forefront, and my clinical nurse facilitators, so my educators at the bedside. We then looked at assistant nurses, enrolled nurses, and enrolled nurse advanced skills, and these are our 2-year vocational trained nurses. We then went to the base grade nurses, so we offered it again to the nurse grade 5s, and these are our newly graduated registered nurses, and registered nurses who just want to be good bedside nurses. And then we ran a number of other programs as well. This year, for the first time, we actually celebrated our new graduates. So those were the graduates who had actually worked for 1 year in our facilities. And you'd be surprised what a simple thank you and a little bit of gratitude does for people. That really sparked their enthusiasm. And I actually ran several senior nurse forums so that we could actually get the message right down to the coalface. We ran some specific nurse manager workshops for our nursing leadership teams. So they were the groups that were actually leading teams themselves. And we offered a suite of 5 self-directed leadership modules that could actually enhance that journey. As well as that, we looked at some additional continuing professional development. And in Queensland in particular, we are particularly blessed to have our industrial partners working with us on what we call the business planning framework and really looking at how we can manage our workforce. And it was interesting listening to the previous speaker who was talking about a 1:22 ratio. In Queensland hospitals in acute medical and surgical, we run on 1:4, 1:4 and 1:7. So running a 24-hour day, 8-hour shifts, 4 in the early, 1 to 4 in the early, 1 to 4 in the afternoon, and 1 to 7 on night duty. So we really are very blessed, and that has been largely due to the work that we as the Executive Director of Nursing across the state, the Office of the Chief Nurse, and our industrial partners have done to make sure that we actually have, and based on a lot of the literature by Linda Aitken. And we also have developed a number of orientation to role packages for nurses and midwives so that no one is ever just thrown into their role without some expectation and some support. So what did we need? Well, I actually needed the commitment of my nurse leaders, and I actually got that. We had to work very collaboratively with our nursing and midwifery education group. We actively participated in every leadership forum and we had workshops to promote and demonstrate commitment to leadership. We looked at a culture of engagement, and we've actually managed to change our culture. Our culture is a very different place. People are actually feel empowered. And you'd be surprised by sharing your journey, and certainly many of the nurse leaders, myself included, actually shared our own leadership journeys, warts and all. I mean, 3 times during my career, it was actually suggested to me that I might like to rethink my career trajectory. And fortunately, that's like waving a red flag at a bull for someone like me. So I didn't give up my career. I actually pursued it. And it is actually rather nice to think back to those people who were my knockers and say to them that I'm actually the Executive Director of Nursing of the largest hospital and health service in the country. But we really wanted to encourage and actively participate in lifelong learning, capacity building, role modelling and mentoring. So what are our outcomes? Well, 2 years down the track, and we have had 4,000 nurses and midwives through our programs. We still are on a journey. It's not a journey that's ever going to end. We do have the support of our Chief Executive currently, who interestingly also comes from a nursing background. We've had a very high participation rate and satisfaction rate. We are actually noticing behaviours are changing, and it's not just about our behaviours to our patients. I was never in doubt about the care that was provided to our patients, but we do know that an empowered nursing workforce will actually deliver quality of care. So it was really important that we actually ensure that that kept going, and it has. But I really wanted nurses and midwives to not only look after the patients in their care, but I also wanted them to look after each other. Because I think that nurses and midwives have a tendency to not look after each other quite as well as we should sometimes. So it was really important that we really flip everything on its ear. Certainly, feedback to me is that we've had some positive personal benefits, and I've actually had a lot of people send me messages thanking me for what we've done to date. Interestingly, we actually won the Queensland Health Excellence in Leadership Award last year for the work that we've done. We are the biggest workforce. We are 46% of the total workforce in Metro North. So it was really, really important that we actually do some really top-notch things. And these are people that are part of my leadership team. But I also heard a quote recently, never be afraid to try something new. Remember, amateurs built the Ark. Professionals built the Titanic, and we all know what happened to the Titanic. So we are on a journey, and I want to share something with you, because one of the things that I think is really, really important is to actually celebrate what we do. We are unique. Nurses and midwives are a very unique breed, and although we're a large mass, and we've heard various figures muted over the last couple of days about the numbers of nurses and midwives worldwide, but we don't look after ourselves very well sometimes, and we don't look after each other. And sometimes just a simple thank you is all that's required. At the end of a shift, somebody walking out and patting you on the back and saying, "Great job, Alanna, had a great day." That's all we need. So this year on International Nurses Day and International Day of the Midwife, International Day of the Midwife being the 5th of May and International Nurses Day being the 12th, we had various celebrations throughout the week to do what we do best, and that's have fun. I think nurses and midwives are pretty good at having fun. We had the support of our chief executive, who actually made it a point of actually coming to all of our ceremonies. We celebrated our successful programs of work and really high-achieving nurses. But I also sent this out to my staff, and I'd just like you to listen to this as I finish. Why have I got no sound? I've got no
Front line, always putting people first. Leaders taking on challenges from bedside to the boardroom. Healing hands and compassionate hearts that care for us throughout our lives. Your skills have eased those in pain and brought new life into the world. And you have the ability to see through the eyes of a patient. It's a challenging profession. The hours are long, but the rewards are worth it. You do more for patients than people realise. You are there for us on our best days. You give us strength at a time when we are at our most vulnerable. Your compassion brightens the lives of so many. The friendships you make are lifelong, and the connections you have with your patients are long-lasting. So thank you for not only taking care of our patients, but of each other. It's that special bond that nurses and midwives share. Thank you for sharing your knowledge. Thank you for holding us to the highest standard of excellence. Thank you for inspiring us every day. And for all of this and so much more, great nurses and midwives deserve our appreciation.
So I'd like to acknowledge the Metro North Communications team, because they actually did that video on the smell of an oily rag. That was not professionally produced, that was produced in-house. All of those actors are nurses and midwives who work in Metro North, so I'd like to pay my respects to them as well. So thank you very much.
Thank you, Prof. Alanna. Is there any question for Prof. Alanna? We have time for one question. No? Okay, thank you. Is there one?
Sorry, I just can't resist asking this question. Okay, you have programs from different group of nurses over there, even for those senior nurses. Okay, from the organization that I come from, SGH, we do have a lot of roles for nurses. And my chief nurse, my nursing add-on, everyone, they came up with a beautiful role. We do have this assistant nurse clinician role, because some of us, we are not resistant to promotion, or we are not resistant to take up the leadership role. Because from morning we have been learning about, we have been listening about this leadership role, and even nurses, we are focusing on young nurses. How about those nurses who are, who can't take up the role, but you can identify them as the leadership role in them? So what different things that you actually do for them, or different programs to encourage them to continue their passion in nursing?
Certainly we do have performance planning and development, and every single nurse in our HHS is required to do that every single year. So our nurse unit managers, our nursing directors would sit down with every nurse every year and outline what goals and what they would like to achieve for the next 12 months. And that's whether you're an assistant in nursing. Even I have to do a professional development plan with my chief executive. It is a requirement. We do that. We can actually identify then what they want to achieve. And certainly our nurse unit managers are very good at selecting talent and figuring out who really should be on a leadership trajectory and what we can do to actually help them get there. We also work very closely with our university partners. diplomas, and we would be encouraging them to go on to look at further study, further education, graduate certificates, graduate diplomas, masters, and even PhDs.
Thank you, Prof. Alanna. Okay, we'll move on to our last speaker, Mr. Nico Sciasci. He's from Italy, and his topic will be on international nurse recruitment, trends and challenges.
Good evening, everyone. Oh, sorry.
My bad.
Oh, you're fine. Thank you. Good evening, everyone. My name is Nico Sciasci. I'm the program manager of the International Center for Nurse Migration, which is a partnership organization between the International Council of Nurses and CGFNS International. The nursing migration landscape has always been around since the beginning of time, but it has been changing. 1 billion out of 7 billion individuals are migrants. Despite polarized political rhetoric about immigration in some countries, the increasing global healthcare professional shortage and overall globalization are leading to increasing flows of migration. Now, in the news, we have heard a lot in every country around the world about migration, specifically in Europe, in the United States as well, but the overall amount of people migrating has not increased that much. It's still around 3%. The movement of nurses from a few source countries to a few destination countries is evolving into different models. And going to the United States, most nurses have positive recruitment experiences, but they also have the ability to vary. Over the last decade, voluntary efforts beyond national immigration and labor law have sought to mitigate challenges in recruitment. As the healthcare professional shortage worsens, more countries are participating in migration. More countries are sending migrants to work as nurses abroad, and there is greater competition to attract nurses, such as the UK, and stopover migration through different countries in the Middle East, as well as circular migration. As you can see, 7.2 million shortage in the year 2017-2018, and an expected shortage of 12.9 million in 2035. So political volatility and source country diffusion provides challenges and opportunities for nurse advocates. From a political perspective and environment around migration, you can see that some of the challenges are support for migrant nurses being afraid to speak up against unethical treatments. In source country diversification, there are fewer structures, both formal and informal, to educate and empower potential migrants. From an opportunity perspective, we see advocating for ethical recruitment unites immigration proponents and opponents, as well as from a source country diversification sector, less dependence on migration as key sources of revenue. For example, remittances, which in the past year have reached 689 billion. As refugee numbers rise, addressing healthcare needs becomes more important. Refugee numbers have been increasing both in absolute and population-adjusted terms, but are not higher than levels in the early 1990s. Unfortunately, this has affected healthcare access for refugees, as it is lacking in many countries, and refugee healthcare professionals' human capital can be used to apply in the case of lacking access for refugees within refugee camps. A perfect example of this is CGFNS is won an MIT Solve Challenge for the creation of a new program for the requalification of refugee nurses and health professionals. This pilot program will be implemented in Jordan in the Zaatari refugee camp, where it's primarily Syrian refugees. 69% of migrant healthcare professionals have had a positive experience being recruited to work in the United States, yet very negative is around 6%. This is an example of one of the significant minority of nurses that have had problematic experience. Edlin Celisfara from the Philippines came to the United States with a staffing agency. Because Celisfara, wanted to change positions, there were threats about reporting her to the immigration authorities within the United States. For breaking her contract, she was sued for $156,000 US, but there was a settlement with no cost and cap on contract breaches fees. And this issue varies by country. So there are various initiatives that work together to promote ethical nurse recruitment. One of the most famous would be the WHO Global Code on Ethical Recruitment Practices, as well as the CGFNS Alliance for Ethical International Recruitment Practices that created its first code in 2009 for the ethical international recruitment of foreign educated nurses, which was later changed to foreign educated health professionals, and the second version that was released in 2017. Working with our partners from the International Organization for Migration, which is the UN agency on migration, and the International Labor Organization, we try to engage these actors into the updates that we do on the on Alliance Code, just as the World Health Organization does for the expert advisory group for the WHO Global Code. So the Global Compact for Migration lends credence to existing efforts. As you can see, the World Health Organization, which is more of a top-down type of code, provides guidance for member states that is applied to all of these member states around the world, whereas the Alliance Code is a voluntary code, which is a bottom-up code that provides guidance for active stakeholders, recruiting firms, as well as employers. A perfect example of an issue in regards to ethical recruitment practices, with Jamaica, they have claimed that there's an exodus of specialized nurses that has impacted its ability to address domestic health care needs. The starting salary in Jamaica is roughly around $8,000 US. The salary for an advanced practice or specialized training plus overtime in Jamaica is $20,000. Now, recruiting firms in both the United States and the United Kingdom are able to offer Jamaican nurses anywhere from $40,000 to $60,000 US. So in 2016, 200 of 1,000 specialized nurses had left Jamaica. Departure is easy as fine for skipping in-country service requirements for $5,000 to $6,000. Now, the Alliance Statement on Jamaica serves as a model that balances individual self-determination rights with best practices to ensure sustainable health systems in source countries. Both the WHO Code and the Alliance Code establish principles to avoid exacerbating healthcare shortages in source countries, as in the case for Jamaica, as well as statement to recertify recruitment firms by the Alliance in 2017, which served to reiterate dual goals of protecting source countries' health systems and ensuring individuals' rights to migrate. Established the following best practices for certified and other recruiters: to avoid outbound advertising for specialized nurses, not to recruit people with public service requirements, and to consider programs to support Jamaican nursing and education. Thank you.
Anyone has any question for Nico? Nico? Nope? Okay, thank you. Thank you so much. We will close the session for today, and thank you for attending till the end.